Okay, imagine this for a second. What if there was some kind of hidden danger, something you couldn't see or feel right away, just quietly setting up shop inside your heart? Not cholesterol, not stress, but an actual, like, invasion.
Exactly.
Today, we're diving deep into something called infective endocarditis.
Mm-hmm.
It's a condition where, well, unwelcome microbes basically decide the inner lining of your heart is a great place to live.
That's a good way to put it. And we've got a detailed text here as our guide today. Our mission really is to unpack this for you.
Right.
We want you to understand what this infection is, who the culprits can be, some might surprise you, and who's more at risk. And it's not always who you'd think, not just people with known heart issues.
Okay.
And, ultimately give you a clear picture of how it's found and how it's treated without getting too bogged down in super technical jargon.
Perfect. So infective endocarditis, let's start with the real basics. What is actually going on inside the heart?
Well, at its core, it's an infection of the endocardium. That's the smooth inner layer lining the heart chambers and valves.
Okay.
And most often, it's the heart valves that get targeted by these infectious agents.
So you think infection, you think maybe a cough or a skin thing.
Yeah.
But these are different. How did they get there?
Yeah, these are tiny organisms, usually bacteria, that have somehow managed to get into the bloodstream.
Right. Okay. So
Yeah.
who are these microscopic invaders causing all this trouble?
The most common ones are gram-positive bacteria, things like Staphylococcus and Streptococcus. You've probably heard of those.
Yeah, staph and strep, sure.
But what's interesting and maybe a bit surprising is the wider range of possibilities. In dogs, for instance, we can see infections from other bacteria like Rickettsia, Bartonella, even fungi.
Fungi, yeah.
Yeah, particularly a type called Aspergillus in dogs. And then you have these really frustrating cases where standard tests don't easily find the cause these culture-negative situations. Bartonella or fungi might be behind those too. And less commonly, you might find things like Brucella, Coxiella, or chlamydia involved.
Fungi attacking the heart.
Yeah.
That's definitely not the first thing that springs to mind. And where specifically in the heart do they usually settle? Which parts?
The aortic valve is the most common spot. That's the big valve letting oxygenated blood out to the rest of the body.
Okay.
The mitral valve between the left atrium and ventricle, that can also be affected, maybe a bit less often. It's actually pretty rare to see it on the right side valves, the tricuspid and pulmonic valves.
Got it. Okay,
Yeah.
so bacteria get into the blood somehow. That
Yeah.
happens, right?
Yeah.
How does that turn into this serious heart infection?
It usually starts with bacteremia, basically, bacteria present in the bloodstream.
Uh-huh.
This might come from an infection elsewhere, like, say, dental disease or a skin infection.
Right.
These circulating bacteria then get a chance to reach the heart valves. And if there's already a little bit of damage or even just some roughness on the valve surface, it makes it much easier for them to kind of latch on and start to multiply. Think of it like Velcro. If the surface isn't perfectly smooth, things stick better.
Okay, that makes sense. So they stick. What happens then? How does it cause the real damage?
Well, once they're attached and growing, the body tries to fight back, of course, but this whole interaction, the bacteria, the body's response, the valve tissue, leads to damage, almost like a little ulcer forming on the valve surface.
Ouch.
And that exposes the collagen underneath. Collagen is a protein that acts like a trigger. Platelets in the blood start sticking to it. The clotting system kicks in.
Right, the coagulation cascade.
Exactly. And you get these layers building up, platelets, fibrin, red blood cells, and the bacteria themselves all tangled together. We call these buildups vegetations.
Vegetations.
Yeah.
Yeah, that doesn't sound good. What effect do these have on how the heart works?
The major problem is that the valves often can't close properly anymore. This is called valvular insufficiency.
So they leak.
They leak. Blood flows backward when it shouldn't, putting a huge strain on the heart. Now, if the aortic valve is badly affected, this backward leakage, or aortic insufficiency, can be really severe and develop surprisingly fast.
How fast?
Sometimes leading to serious congestive heart failure, or CHF, in just weeks or maybe a couple of months. It can be quite dramatic. If it's the mitral valve, the progression might be a bit slower, more gradual.
But these vegetations, they don't just cause problems right there on the valve, do they? I seem to remember they can break off.
Yes, exactly. And that's a critical point. These vegetations can be fragile. Bits can break off and travel in the bloodstream.
Like little infected clots?
Precisely. We call them emboli. These infected emboli can float downstream and get stuck in smaller blood vessels in other organs. This can cause a blockage, cutting off blood supply that's an infarction, like a mini stroke in that organ.
Wow.
Or they can actually seed a new infection there. We call that metastatic infection.
Where do they typically end up?
Common targets are organs like the spleen, the kidneys, the brain, even skeletal muscles.
So it's definitely not just a heart problem. What other body systems can get dragged into this?
Oh, the impact can be pretty widespread.
Mm-hmm.
Within the cardiovascular system itself, besides the valve leakage, you can get irregular heartbeats, arrhythmias, and even inflammation of the heart muscle itself, which is myocarditis.
Okay.
Then the central nervous system can be affected. You might see weakness or paralysis, nerve issues, even changes in mental state.
And the blood itself.
Yeah, there can be an increased tendency for clots to form elsewhere in the body, and in really severe cases, a dangerous condition called DIC, disseminated intravascular coagulation, can happen. That's where the clotting system basically goes haywire.
DIC sounds terrifying. Anywhere else?
Mm-hmm. The musculoskeletal system, you can get infections or inflammation in the joints, sometimes weird bone growth, even inflammation of the discs in the spine.
Joints, like arthritis.
Sort of, yeah, infectious or inflammatory arthritis. Then the kidneys and urinary system, you can get blockages from those emboli, kidney damage from the immune system's reaction, UTIs. And the respiratory system, too. Fluid can build up in the lungs because of the heart failure, or those emboli can travel to the lungs, causing pulmonary emboli, which are blood clots in the lungs.
It really does touch almost everything. So thinking about who gets this, is it mainly older animals or ones we already know have heart problems?
Well, pre-existing heart conditions are definitely a risk factor, but it's interesting to look beyond that. Species-wise, we see it mainly in dogs. It's actually quite rare in cats.
Okay.
And within dogs, certain breeds seem more prone, particularly middle to large breeds, and, importantly, breeds that tend to get a condition called subaortic stenosis.
Subaortic stenosis. Refresh my memory, that's a narrowing.
Exactly. It's a narrowing in the outflow tract just below the aortic valve.
Right.
This narrowing forces the blood through a smaller opening, creating turbulent flow, like rapids in a river.
Ah, okay.
And that turbulence can actually damage the inner lining of the heart right there, making it easier for any circulating bacteria to stick.
Gotcha. What about age?
It's most commonly diagnosed in middle-aged dogs, say 4 to 8 years old, but honestly, it can happen at any age.
And sex. Does that matter?
Interestingly, yes. Most studies seem to report that male dogs are more often affected than females. The reasons aren't totally clear, but it's a consistent finding.
Huh. That is unexpected. Okay, so if this is happening, what kind of signs should someone or their vet be looking out for? What clues might point towards endocarditis?
Yeah, this is where it gets tricky because the signs can be so incredibly varied. It's known as the great imitator for a reason.
The great imitator. Okay.
Some types of bacteria, the gram-negative ones, tend to cause really rapid, severe illness. Gram-positive infections might develop more slowly, be more insidious. But the key thing often is that the general signs feeling unwell systemically often overshadow any obvious heart-specific signs, at least initially.
So not necessarily chest pain or things like that right away.
Not always, no. You might be looking for clues in the history. Has there been a recent infection anywhere?
Like what?
Skin infections, dental problems, GI issues, urinary tract infections, prostatitis in male dogs, any potential source of bacteria.
Okay.
Also, a history of things that might weaken the immune system, long-term steroids, for example, or known risk factors like that subaortic stenosis we mentioned, recent surgery, wounds, abscesses. These can all be relevant.
And the common signs someone might actually notice at home.
Things like lethargy, just being really tired, weak. Fever is common. Loss of appetite, maybe vomiting or diarrhea, and sometimes lameness or joint pain that seems to move around.
Lameness. How does a heart infection cause lameness? That seems disconnected.
Exactly. That's the imitator part. It could be from those emboli causing little infarcts in muscles or joints, or from immune reactions affecting the joints.
Ah, okay. So the physical exam findings must be pretty varied too.
All over the map. Fever and just generally looking unwell, absolutely. Maybe difficulty breathing if CHF is starting. Different kinds of irregular heartbeats or arrhythmias, that shifting lameness we talked about.
And you'd listen for a murmur.
Definitely. A heart murmur is a very common finding. Often it's a systolic murmur heard when the heart contracts. But there's a specific type, a to and fro murmur.
To and fro.
Yeah, you hear it during both contraction and relaxation. That's highly suggestive of an aortic valve problem. Also, hearing a diastolic murmur when the heart relaxes, especially combined with really strong pulses felt in the hind legs, the femoral pulses, that strongly points towards advanced aortic endocarditis with significant leakage.
Okay, so we've got the what, the who, the signs. Let's dig into the why a bit more. What really allows this infection to grab hold, and what are those main risk factors again?
Well, the fundamental starting point is bacteria getting into the bloodstream, the bacteremia. The source could be, honestly, quite varied. Dental disease is a big one, bacteria from the mouth getting in during chewing or dental procedures.
Right.
Or infections elsewhere, bone infections, prostate infections, skin infections, you name it. Even invasive procedures, things like placing catheters, can sometimes accidentally introduce bacteria.
And you mentioned subaortic stenosis is a key risk because of the turbulent blood flow damaging the lining.
Exactly. That anatomical defect creates the perfect environment for bacteria to stick.
What else makes an individual more vulnerable?
Anything that suppresses the immune system is a major factor, so long-term or high-dose steroid use is a big one.
Okay.
Also, conditions like cancer or treatments like chemotherapy drugs that suppress immunity, basically anything that lowers the body's defenses.
Right. Okay, so the vet suspects endocarditis. Signs are there, maybe some risk factors. How do they actually confirm it? What's the diagnostic process?
Well, first steps often involve ruling out other things that can look similar.
Like what?
Just general bacteremia from some other source, maybe not settling on the heart valves. Immune-mediated diseases can cause weird multisystemic signs too. And of course, other causes of left-sided heart failure, like dilated cardiomyopathy, where the heart muscle itself is weak.
Makes sense. Then you move to lab tests, blood work.
Absolutely. Blood work gives lots of clues. Often you'll see what's called an inflammatory leukogram, basically. The white blood cell counts show the body is fighting a significant infection. High neutrophils, maybe a left shift.
Okay.
But interestingly, if the infection is more chronic or kind of walled off, the white count might actually look normal, which can be misleading.
Mhm.
You might also see anemia, often non-regenerative, meaning the body isn't making enough new red cells. And low platelets, thrombocytopenia, is pretty common too.
Anything else in the chemistry panel?
Sometimes you see changes in proteins like albumin, maybe glucose or liver enzymes, especially if there's severe sepsis, but they aren't always consistent. Kidney values might be elevated, and you might see protein in the urine if the kidneys are being affected by emboli or immune complexes.
Okay, but how do you find the actual bug?
Blood cultures, they're absolutely critical. The gold standard is collecting multiple samples over time.
Not just one.
Ideally, no. Usually 3 or more samples, maybe an hour apart over a 24-hour period before starting antibiotics if possible. You want to grow the same organism from at least 2 samples to be confident it's not just a contaminant.
Right.
And you need both aerobic and anaerobic cultures. There are even special blood culture bottles with antibiotic-removing resins if the patient has already had some antibiotics.
What if the cultures are negative?
That definitely happens. Could be due to prior antibiotics, or maybe it's one of those difficult-to-grow bugs like Bartonella. That's where PCR testing on the blood can be really helpful, looking for bacterial DNA.
Got it. So multiple cultures are key. What about culturing other things like urine?
You might culture other sites if you suspect them as the source, like urine or maybe the tip of an IV catheter if one was removed. But you have to be careful. Finding bacteria in the urine doesn't automatically mean that's the source of the heart infection. It could be a separate issue. And yeah, sometimes specific tests for infections in the prostate, kidneys, or bone might be done. Also, sometimes nonspecific immune markers can be up, which can confuse things. And if Bartonella is suspected, there are special growth media and PCR tests just for that.
What about looking inside? Imaging, X-rays, ultrasound?
Chest x-rays might show if the left side of the heart is enlarged and maybe signs of heart failure like fluid in the lungs. Very rarely you might see calcium on the valves. But echocardiography, the heart ultrasound, that's really the most valuable imaging tool here.
Because you can see the vegetations.
Exactly.
Yeah.
Echo lets you visualize those vegetations, the bacterial clumps on the valves. They're often pretty obvious on the aortic valve. Sometimes on the mitral valve, it can be a bit harder to tell them apart from other kinds of valve degeneration, especially early on.
Do they look different over time?
Yeah, they can become more dense and bright looking on the ultrasound, more echogenic as they get older and more organized.
Any other tests used? ECG, joint taps.
An ECG, measuring the heart's electrical activity, might be normal. Or it could show signs of heart enlargement, arrhythmias, or conduction problems like AV block, which can be a clue, especially if the aortic valve root is involved. And if there's significant joint swelling or pain, yeah, a joint tap might be done. Analyzing the fluid can show inflammation or infection, but sometimes it's hard to definitively distinguish between infection and an immune reaction just from the fluid.
And if, unfortunately, an animal doesn't make it, what does the pathology show? What's seen after death?
Pathology usually confirms an enlarged heart, typically the left side. You'll see those vegetations, maybe clots, stuck to the affected valves. Microscopically, there's evidence of infection, maybe inflammation, bleeding, or tissue death in the heart muscle.
And the emboli.
Yes. You almost always find evidence of emboli, especially kidney infarcts, little areas of dead tissue in the kidneys caused by blocked vessels. That's why you often see protein in the urine or kidney issues. You might also find infections spread to the kidneys, spleen, or other organs, and signs of lung issues like fluid or bleeding.
It really does paint a very serious picture. So moving on to treatment. What's the approach? What does recovery look like?
Well, the key is urgency. Early suspicion, fast diagnosis, prompt and aggressive treatment that gives the best chance. If it's caught early and only involves the mitral valve, the prognosis can actually be reasonably good with aggressive care.
Okay. What does that immediate care involve?
Supportive nursing care is crucial. Often that means aggressive IV fluids to support circulation. But you have to be really careful if the patient already has signs of congestive heart failure or kidney disease.
Right. Too much fluid could make things worse.
Exactly. In those cases, fluids might need to be restricted, just enough for maintenance needs. And careful monitoring of electrolytes, especially potassium, is vital.
And talking to the owner.
Absolutely critical. Setting realistic expectations is important. The prognosis is generally considered guarded even for just mitral valve involvement, and unfortunately, it's often grave if the aortic valve is significantly affected.
Okay. Medications. Antibiotics have to be the main thing, right?
Yes, antibiotics are the absolute cornerstone. But antibiotics might not be able to reverse existing structural damage to the valve, especially that severe aortic insufficiency. That damage can be permanent and life-limiting.
So how are antibiotics given?
Typically, you start with high doses of bactericidal antibiotics, ones that kill bacteria given intravenously, usually for at least a week, maybe longer.
Okay, 5E first.
Then often transition to subcutaneous injections under the skin for another week or more. Long-term oral antibiotics might be used eventually, but only after a good initial response to the injectables and once the inflammation has calmed down significantly. This often means months of treatment.
How do you pick the first antibiotics before you even know exactly which bacteria it is from the cultures?
Good question. You make an educated guess based on the most likely culprits. Staph and strep are common. So you start with broad-spectrum antibiotics that cover those well.
Like what?
Maybe a penicillin-based drug or a first-generation cephalosporin. For really sick patients, septic patients, you often use a combination while waiting for culture results. Maybe adding an aminoglycoside like gentamicin or a fluoroquinolone like enrofloxacin.
You mentioned risks with those.
Right. Aminoglycosides can be tough on the kidneys and potentially worsen heart failure, so you have to use them cautiously, monitor kidney function closely. Fluoroquinolones are generally safer in that regard. Sometimes newer generation cephalosporins or drugs like ticarcillin clavulinate are used. The key is hitting hard initially.
And what about treating the heart failure itself if it develops?
Yeah, you manage that with standard CHF medications. Things like pimobendin, ACE inhibitors, spironolactone, maybe amlodipinus if blood pressure is high, and definitely diuretics like furosemide to get fluid off.
Okay.
For really acute, severe fluid in the lungs, pulmonary edema, you might need oxygen therapy, maybe nitroglycerin, high-dose furosemide, potentially other drugs like hydralazine.
Are there any treatments that should definitely be avoided?
Yes. You generally want to avoid antibiotics that don't penetrate well into fibrin clots, since the vegetations are made of fibrin. Sulfonamides are an example. And steroids are usually contraindicated because they suppress the immune system, which you need to fight the infection.
Makes sense. What about blood thinners? You hear about them for clots. Are they used here?
That's actually pretty controversial in endocarditis. Standard anticoagulants like heparin aren't typically recommended, at least in humans, because there's a risk they could increase bleeding, maybe from those damaged valves or emboli sites.
Oh.
However, some Antiplatelet drugs like aspirin or clopidogrel, or maybe low molecular weight heparin like dalteparin, might be considered in some cases. The thinking is they could potentially help reduce emboli formation or bacterial spread, but the evidence isn't super strong and it's decided case by case.
So once treatment starts, how do you know if it's working? How do you monitor?
You watch closely for signs of resistance or treatment failure, like the fever coming back or the inflammatory changes in the blood work persisting or worsening.
Boy.
Adjusting the antibiotics based on the culture and sensitivity results once you have them is absolutely crucial. Regular checkups, repeating blood work after they go home is important, and doing repeat blood cultures about a week after stopping the long course of antibiotics is usually recommended, or anytime the fever comes back to make sure the infection is truly cleared.
Okay, that makes sense. What about preventing this in the first place? Is there anything that can be done?
Well, some general principles apply. Limit the use of things like IV catheters to only when necessary, make sure they're placed aseptically, and change them appropriately.
Hmm.
For dogs we know have moderate to severe subaortic stenosis, giving prophylactic antibiotics before a procedure might be a good idea, before things like dental work or other surgeries considered dirty where bacteria might easily get into the bloodstream.
Okay.
And just generally being careful with steroid use, avoiding careless or unnecessary long-term administration.
And even with treatment, what are the main complications you still worry about?
Even with good treatment, congestive heart failure can still develop or worsen. Kidney failure is a risk from the emboli or immune complexes. Spread of infection elsewhere is possible. And sometimes, even after the infection is cleared, you can get persistent or late-onset immune-mediated joint problems.
So wrapping up, what's the overall outlook? What influences whether things go well or poorly?
Generally, a better outcome is associated with catching it early, a shorter time between the bacteremia starting and getting diagnosed and treated. Quick diagnosis and aggressive, appropriate antibiotic therapy are key.
And risk factors.
Interestingly, having received steroids recently seems to correlate with higher mortality. And as we said, the prognosis is much, much worse if the aortic valve is significantly involved compared to just the mitral valve.
Right.
With mitral valve disease alone, survival is possible, but even then there's a risk of late-onset CHF down the road if the initial treatment wasn't quite enough or the valve damage was already severe.
Okay, let's bring this home for you, the listener. The big takeaways from this deep dive. Infective endocarditis is serious. It's an infection inside the heart, usually on the valves. Recognizing those risk factors like subaortic stenosis or things that weaken immunity and spotting those often vague systemic signs early is really critical.
It really is.
And if it's suspected, getting to the vet quickly for thorough diagnostics, blood cultures, echo, and starting targeted, aggressive treatment is absolutely essential for the best possible chance.
Yeah. And this whole discussion really highlights something important, I think. We often think of infections as external things, maybe a cut, a wound.
Right.
But endocarditis is a stark reminder of how an infection starting somewhere else, maybe something seemingly minor like dental disease, can travel and cause devastating consequences internally, right in the heart.
It really shows how interconnected everything is.
Exactly. It makes you appreciate how complex the body is and how sometimes our defenses can be overwhelmed in unexpected ways. So the final thought really is, if you have any concerns about your own health or the health of your pet, don't hesitate. Talk to your doctor, talk to your veterinarian. That's always the best course of action.